So my name is Yubi,
And I'm Kaylee.
and we have carpal tunnel syndrome. So a little bit about our patient. Her name is Marlo. She is 50 years old, from Austin, Texas. She works as an administrative assistant for a Spectrum internet company. She enjoys gardening in her spare time, and she also is the mother of 2 college-age kids. About her injury, so again, she has bilateral carpal tunnel syndrome, and that's basically because she spends from 8 to 5 just typing at her desk in front of a computer, Monday through Friday. And then when she gets home, she is digging and uprooting weeds and planting new flowers in her garden. And so that's really stressing her wrists. So some signs and symptoms that she presents with is diminished strength, loss of active range of motion with wrist flexion and extension, and minor atrophy of the thenar muscles. Some symptoms include tingling, numbness, weakness, and pain in the wrist and forearm, especially at night.
So let's talk about the anatomy of the carpal tunnel. The carpal tunnel contains 9 flexor tendons, which includes the flexor pollicus longus, the 4 flexor digitorum superficialis, and 4 flexor digitorum profundus tendons, and also the median nerve. So the transverse carpal ligament is really what forms the roof of the carpal tunnel, and the 8 carpal bones is what forms the floor. A lot of times when the patient presents with tingling and numbness and weakness, that's due to inflammation or swelling, which is creating this pressure on the median nerve within the carpal tunnel. So some other precautions. In an emergency situation, we would perform a carpal tunnel release. This is pretty much where the carpal tunnel, or the transverse carpal ligament is cut to help reduce the pressure placed on the median nerve. Some other concerns would be things like comorbidities such as diabetes or osteoarthritis, anything that might interfere with our rehab plan. Also, the inability of the patient to work or perform just normal activities of daily living, and also the atrophy of the muscles around that joint. So some precautions is that, again, they may have some comorbidities or underlying issues that we as clinicians may not even know of, and then also things like rheumatoid arthritis or anything else that might impair that joint.
So getting into her rehab for phase 1, our goals we have is that she will have decreased pain from a 5 out of 10 to a 2 out of 10 via the NRS by April 14th, and that she will have decreased edema in both wrists from 9 inches to 7 inches via girth measurement. Some modalities include therapeutic ultrasound and massage. Interventions are splinting, NSAIDs, corticosteroid injections, and some exercises would include towel scrunches with her fingers, digging through Play-Doh to get objects or beads out, and finger taps. For phase 2, we really want the patient to increase active range of motion of bilateral wrist flexion from 50 degrees to 85 degrees by April 16th. Patient will be able to complete 15 wrist flexion pulls with TheraBand pain-free by April 16th. Exercises for phase 2 would be planking on a Bosu ball, which would really work on that wrist strength and proprioception. Wrist extension pushes off of the edge of desk to really stretch her muscles there, and TheraBand pulls for wrist flexion.
Phase 3, our goals are that the patient will be able to hold a plank for 30 seconds unassisted on a Bosu ball by April 18th, and also that the patient will be able to perform the upper extremity STAR excursion test pain-free by April 18th. Exercises that will help our patient achieve these goals would be things such as like the bird dog progression on an Eric's pad. This is a similar body position to when she's gardening. Also wall push-offs with a clap and planks at various lengths of time and on different surfaces. For phase 4, our goals are that the patient will be able to plant 10 flowers in under 30 minutes without pain by April 20th, and also that the patient would be able to type one page double-spaced on the computer free of pain by April 20th. Some exercises that would help with these goals would be things like supine ball drops, where the patient would catch the ball and then throw it back up to the clinician while laying prone. Or I'm sorry, supine. That'd be really hard to do while she was prone. Also dribbling a basketball around an obstacle course, and medicine ball slams, which kind of simulates gardening with a pickaxe.
So the difference between operative and non-operative. For operative, with surgery, what we really want to do is, or what it does, is that it relieves the symptoms significantly better than just splinting the wrist as you would do non-surgically. The main goal is to minimize the pressure that's put on that median nerve and increase the volume or space in the carpal tunnel. And then depending on the patient, the healing time can take from 6 weeks up to a year.
So our non-operative rehab plan, really it just reduces the risk for infection or any other accidental damage to surrounding tissues. Normally the non-operative treatment is reserved for mild to moderate cases, whereas the surgical route is more for severe cases, or cases that show no improvement whatsoever even after rehab. And typically symptoms improve with rest and worsen with activity. Thank you. There it is. Thank you.
Thank you.
I can find the keyboard.
There you go. Just had it. Oh my gosh.
That's so bad.
How she sustained the injury, I guess, is that she works at,
It's okay, we can start.
yeah, sorry.
It's not a big deal. And also that the patient will be able to perform the upper extremity STAR excursion test pain-free by April 18th, 2018. So in an emergency situation, surgical techniques. Drop your butt down just a little bit. There you go.
Get it? Because I'm dying. You can kneel or like kneel on the table and then drop it? Or... Oh, okay.
Ready?
Yeah.
That's funny.
That's it.
Thank you. Yay. Round of applause.